seen. So before deciding the treatment for her friend, commonly we will be doing the examination. We will taking the history of the patient, and then we will check on the intraoral and extraoral examination. Then we will be doing investigations. We will take radiograph. Preferably, we will do cephalometric, and the orthodontist and oral maxillofacial surgeon will be discussing on the treatment plan. So if the treatment plan is agreed, then they will be doing a period of orthodontic treatment around 12 to 18 months to align this in preparation for the surgery. So before doing the jaw surgery, they will do the surgery on the study cast. So followed by the jaw surgery, we will be doing they will complete it with another short period of orthodontic treatment, and lastly, maintenance. So here are the few treatment options probably given to her friends, but I assume that she had done orthodontic surgery. So for gross modification in dentofacial deformities, only orthodontic treatment alone. And in severe dentofacial deformities, we can do gross modification, but it is not done on her friend because it is only in growing patient. And this modality usually has limitation and only few millimeters changes can be seen. And example of gross modification is high pull headgear or myofunctional appliances. And second, orthodontic camouflage. This is dental compensation that is built into musculoskeletal malocclusion. So if timing of orthodontic treatment is poor, it may not give desirable result. Last is orthodontic surgery. It is a surgical repositioning jaw or dental alveolar segments. It is where the correction of severe skeletal discrepancy done after growth is ceased for correction of severe skeletal discrepancy. Next. So why orthodontic surgery is done on her friend? Because orthodontic surgery usually help patient with masticatory impairment, protruding jaw, difficulty in swallowing, and asymmetrical facial appearance. So these problems can be seen on CT's friend condition. So the objective of this surgery is to achieve best function, to improve facial appearance for aesthetic purpose, and will provide best stability. Next. So when is the best timing to do the surgery? When patient growth potential is over, because we need to do surgery on the jaw. So for protruded mandible, the most common surgical done is intraoral bilateral sagittal split osteotomy because it is highly cosmetic procedure and it is done intraorally, and because of the broader bony contact of osteotomized segment, it will ensure good healing. And next, subcondylar ramus osteotomy. That's all. Thank you.
Okay, you well done actually, but you didn't put it in words that Siti can understand. This is like talking to another dentist. So they will look at that, like your OSCE, they ask you to tell the patient names. Your words must be what that patient can understand.
Okay.
Okay, just make that correction lah. Otherwise, you've done well. Okay, that's
Thank you.
Adila. Who's next? Anybody got questions for Adila or not?
Okay, good morning, Dr. Sundari and my fellow classmate. I'm Afika, so I will be answering question number 2, which is to describe the surgery that could have been done for the Siti's friend. So from the information given, we know that Siti's friend has a very protruding jaw, and recently she had gone surgery to correct the problem, and after the surgery, the facial appearance of the Siti friends already increases, and the problems with the chewing already solved. So for the introduction, I will talk a little bit about the orthodontic surgery. So what is the orthodontic surgery? The word orthodontic is actually comes from the Greek word where the ortho means straighten and the nectia means jaw. So basically it means to straighten a jaw. So by definition, the orthodontic surgery is defined as the art and science of diagnosis, treatment planning, and execution of treatment to correct musculoskeletal, dental-osseous, and soft tissue deformities of the jaw and associated structure. So this is the flow chart of the diagnosis and the treatment planning, starting from the examination until the retention and the maintenance. But I will not cover each and every point. I will be only focusing on the surgical part. So for the treatment planning, it can be divided into 3 phases, which are phase 1, phase 2, and phase 3. So for the phase 1, the pre-surgical orthodontic is done to correct the occlusion of the patient. The aim of the pre-surgical orthodontic is to move the teeth to a more desirable position over the basal bone. And it also helps in facilitate the planned skeletal and facial correction. Moving on to the phase 2, this is where the surgical treatment is done. So as we all knew that the CT span has a very prognatic jaw. So the surgical treatment is done to move back the mandible to the desirable position. And for the phase 3, it is done 4 to 6 weeks after the surgery. And after the surgeon have confirmed the satisfactory healing from the patient, the stabilizing arch wire are replaced by the light wire and occlusion is allowed to settle. After that, the follow-up have to be arranged by the dentist for a maintenance purpose. Next, so when the patient come with any dentofacial deformities regarding the mandibular osteotomy is considered. So for the mandibular osteotomy, it can be divided into 2, which are the mandibular body osteotomy and the mandibular ramus osteotomy. For the mandibular body osteotomy, it can be further divided into intraoral mandibular body osteotomy, which consists of the anterior, posterior, and the mid symphysis. For the anterior body osteotomy, the osteotomy is done anterior to the mental foramen. And while for the posterior body osteotomy, the osteotomy is done posterior to the mental foramen. And for the mid symphysis osteotomy, the osteotomy is done at the middle of the body of the ramus. And for the segmental subapical mandibular surgery, it is further divided into anterior, posterior, and total subapical mandibular osteotomy. For the genoplasty, this genoplasty is usually done when there is a deformities of the chin. So the purpose of this genoplasty is either to augment, reduce, straighten, or to lengthen the chin of the patient. So for the mandibular ramus osteotomy, it divided into subcondylar ramus osteotomy and intraoral bilateral sagittal split osteotomy. So from what I read in article, the most commonly used mandibular osteotomy in mandibular prognatism is intraoral ramus osteotomy and intraoral bilateral sagittal split osteotomy, because both of this procedure is done intraorally, so it has a very high aesthetic value. But comparing with these two, the intraoral bilateral sagittal split osteotomy is more recommended because it has a rapid healing compared to the intraoral, while the intraoral ramus osteotomy have a very difficult accessibility because the incisions start at the sigmoid notch of the mandible. So I will explain in detail about the bilateral sagittal split osteotomy. So just like I said, bilateral sagittal split osteotomy is the most versatile and popular mandibular osteotomy. This technique is first introduced by Otway Jessel and Trauner in 1957, and it have undergo modification until then. And this surgery can be used to correct both mandibular prognatism as well as the retrognatism. So basically what this surgery does is it split the ramus and the posterior body of the mandible sagittally, which allow the mandible to move backward or advance the mandible anteriorly. So this surgery has a very cosmetic procedure because it is done intraorally. Moving on to the procedure. First, we have a big bite block. A bite block has to be inserted on the opposite side of the mouth, between the upper and the lower teeth for a better accessibility and to project the ramus anteriorly. So after that, an incision is made on the anterior aspect of the ramus, running down to the mid-ramus, overlying the external oblique ridge until the region of the first molar. So from the region of the first molar, the incision extended and curved down to the buccal vestibule. The mucopharyngeal flap elevation is done above the lateral aspect of the mandible and the molar region until the inferior border. After that, the medial parietal elevation is done, and the level of the lingula and the mandibular foramen should be located. The level of the mandibular foramen should be located because we want to do the dissection above the mandibular foramen, and the lingula is exposed subperiostally using an elevator. And then the osteotomy is done by cutting the cortical bone above the lingula, and the cut extends just posterior to the mandibular foramen. Next, the cut is extended to anterior border of ramus of the mandible, and it is continued along the external oblique ridge until the second molar region. Here, a vertical cut is made, just enough to reach the cancellous bone. And the cut should include the inferior border to control the splitting of the ramus. After the cortical cut is completed, osteotome is mailed to the side from the medial cut to vertical cut. So basically, this osteotome is functioned to check the completeness of the bone cut, and it should be directed laterally to prevent any injury to the neurovascular bundle. After all this procedure is done, the same procedure is repeated on the opposite side. So in case of this CT span where she have a prognatism of the mandible, the distal segment is pushed back, and when we push back the mandible, there will be overlap of the two segment in the molar region. So this excess bone have to be cut off by taking a vertical cut distal to the previous cut, and then the fragment will be checked for proper approximation and fixation by plate or screw is carried out. So this is the illustration for your better understanding. In a very simple word, first we do the incision from the anterior border of the ramus until the inferior border, and then we raise the flap, we cut the bone, and then we move the mandible backward, sit back the mandible, and the overlap bone or the excess bone is cut off using a vertical cut, and we fix it using a plate or the screw so that it doesn't move. So this is the image of the surgery from step by step. And for the wound closure, the wound can be irrigated with the saline, and hemostasis can be achieved by using chromic catgut or Vicry suture. So for the complication that can occur during the surgery is, first, there will be chance of injury to the neurovascular bundle. So this is occur because we mistakenly cut the nerve fiber. So next is the malpositioning of the condylar segment. So this complication usually occur during the fixation period, and the patient that suffer with this problem, the malpositioning of the condylar segment, usually appear with the open bite. And to correct this, the surgery recorrection have to be done. Next is the bed split or multiple indivisible split during the surgery, and the excessive bleeding might occur. For the advantages of the bilateral sagittal split osteotomy, it has a very greater flexibility in repositioning the distal tooth-bearing segment, and it also enhance the healing because it's better cancellous bone contact. Next, there will be no external scar because it is done intraorally, and minimum alteration in the position of condyle and the muscle of mastication. For the disadvantages, there will be chance of injury to the inferior alveolar nerve during the surgery happen. That's all for me.
Okay, that was good, except one addition lah. Sometimes if the movement is too much, more than 1 cm, then we don't do only mandible. We may have to divide it between the mandible and maxilla. So maybe they need a maxillary level 1 as well. Okay, just for your information lah. But I expected you memang to bagi tahu the surgery for the mandible only. Maybe you can put one line. If the movement was large, maybe they would have done maxillary surgery as well lah. Okay, because if too much of movement, nanti ia akan balik kepada asal. The muscle will pull it back. So cannot overstretch but actually class 3 not so bad lah. Putting back, your muscles are not stretched. But class 2 coming out to class 1, then it is more stretched. But anyway, even mandible, if it is even class 3, if we have to move so much, we usually will divide it up into the maxilla as well. Okay, anybody got any questions on her part? Okay, next is Ahmad Haziq. Okay, your turn.
Hello, doctor and fellow friends. Just now, my friend presented about Siti's friend. Now, I'm going to present about Siti herself. So, question 3 is Siti wants to know what can be done for her. State the various treatment options available so that she can make an informed choice. So, the information given is Siti has mandibular retrognatism with a very small chin, class 2 skeletal pattern, and class 2 division 1 incisor relationship, with an anterior open bite and overjet of 0.5 centimeters. So before that, what is retrognathia? Retrognathia is a condition where the lower jaw is set back further compared to the upper jaw. So if a class 2 malocclusion happens when you have a smaller jaw than the usual lower jaw, it's also known as retrognathia. So the treatment options, if the problem is purely dental, and the patient is happy with her appearance and aesthetic and only wishes to correct her occlusion, the solution is camouflage orthodontic. If the patient already have a good occlusion but a retracted chin, a genioplasty or chin surgery is recommended. As Siti has an open bite and overjet, it's recommended to do orthodontic treatment before or after surgery if she is choosing this treatment. When there is a skeletal problem, the indicated treatment is usually orthodontic surgery, which may or may not be accompanied by a orthodontic treatment depending on the case. So, what is camouflage orthodontic? It's a dental problem corrected, therefore making the skeletal problem no longer apparent or obvious. It's usually done in a mild skeletal discrepancy case. So, for class 2 malocclusion orthodontic treatment, non-extraction treatment with class 2 elastics can be done. Retraction of upper incisors into premolar extraction space and the distal movement of upper teeth. As for chin surgery or genioplasty, a genioplasty can correct a small chin. A small chin often accompanies a severely receded lower jaw. Typically, the surgeon can alter the jaw and restructure the chin during the same surgery. The surgeon cuts a piece of the chin bone on the front of the jaw, move it forward and secure it in a new position with plates and screw. The last one is orthodontic surgery. For this case, mandibular osteotomy. It's a corrective jaw surgery to correct deformity of middle and lower third of the jaw. Involves moving the bones of the lower jaw. So the procedure, the first, make an incision into your gums on each side of the lower jaw, just behind your molars. Second, cut the bone of the lower jaw, which allows the surgeon to carefully move it into a new position. Third, move the lower jawbone either forward into a new position. Fourth, place plates or screws to hold the adjusted jawbone in its new position. And lastly, close the incision in the gums with stitches. My friend will explain about this orthodontic surgery in more detail.
Okay, that's also well done, but again the language lah must be more suitable for Siti to understand.
Yeah, I tried to make it.
Yeah, but you see, you got no choice. What when you have a patient, real patient, you have to talk in the language they will understand, kan? So now you better practice lah, because you will not be doing the surgery, but you may be the person who is explaining it usually. Until you become a specialist, you won't do the surgery, but you are the person who will be clerking the patient, doing the investigations, explaining, taking consent. So you must learn how to speak in the patient's language such that they can understand. Okay, anybody got any question for Ahmad Haziq? Tak ada. Okay, next person.
Okay, good morning to Dr. Suntari and fellow classmates. I'm Aimi and my question is, explain in detail the whole management involved if Siti decided that she wanted to proceed with the orthodontic surgical option. So next. So by definition, it is the art and science of diagnosis, treatment planning and execution of treatment by combining ortho and oral and maxillofacial surgery to correct musculoskeletal, dental osseous and soft tissue deformities. So the objective is to help patients with those indications, and for Siti, since she has a retrognatic mandible, we are going to help her regarding the issue. So there are 3 phases for the surgery. The first phase is pre-surgical treatment, which involves orthodontics and the surgical plan that will be discussed together with CT. Second is the surgical treatment, which is the orthodontic surgery. Third is the post-surgical treatment, where we'll still use orthodontics to settle down the occlusion, and then we restore any carious tooth if there's any, and also follow up of the surgery. So first phase is we are going to evaluate and diagnose Siti's condition. There will be a discussion at the joint clinic attended by the orthodontist and the surgeon to create a treatment plan for Siti, and they will interview Siti's together. The discussion will involve Siti's concerns and chief complaints, and then they will do a clinical evaluation, radiographic and imaging analysis, and also a dental model analysis. So for first element is they will ask Siti's concern and chief complaint, and these are such questions that they can interview, such as what are Siti's concerns or problem? Have you had previous treatment and what was the outcome? Why does Siti want the treatment? Is it because to correct occlusion or because for aesthetic purpose? And next, they will ask Siti's expectation, and also inform the time consumed from pre-surgical to post-surgical, and also inform the cost involved of the whole process. And also, if there is any question and doubts by Siti, they will sort out before the surgery will happen. And they will also must warn the possible risks and complications that will occur during the surgery. So such complications and post-operative sequelae that might happen is usually patient will have edema but will resolve in 2 weeks. And patient might have diminished lip sensation because the injury of the inferior alveolar nerve might happen, because 2/3 of patients will experience sensory deficit even after a year. Such complications that might occur is there might be permanent damage to the inferior alveolar neurovascular bundle, and then the malpositioning of the condyle segment, and also excessive bleeding because of the nerve damage. So next, after they've interviewed, they will clinically evaluate Siti regarding Siti's history, the medical, the dental history, whether there's allergies, habits, and also they will do a physical examination. Next, they will take clinical photographs for the documentation purposes. And next, they will do a facial aesthetic analysis in the frontal view and profile view. They will sit Siti upright at the eye level. The pupillary plane should be parallel to the floor. And then the Siti's head will be positioned in a way that the clinical Frankfurt horizontal plane is parallel to the floor. And then Siti is asked to position the tongue at the most posterior aspect of the palate, and teeth must be close together to get a centric relation. The lips should be relaxed because they will evaluate the tooth to lip measurement, lip incompetence, and chin position. And then patient CT is asked to look straight and remain steady. And then clinical photographs will be taken in frontal and profile views for records and photographic analysis. Next. So these are the normal values, normal values that patient usually has. So these preoperative measurements must be taken before surgery is taken out. Next. They will do an intraoral examination also. They will examine their CT's occlusal relationship. So we know that she has class 2 relationship, whether there is any tooth size discrepancies, any crowding or spacing, also if there is overjet or deep bite, but we know that the CT has open bite, anterior open bite. They will do a periodontal evaluation and also see if there is a missing or carious tooth, and also evaluate the curve of Wilson and curve of Spee. Next, they will do a cephalometric analysis. So this is a 2D diagnostic tool that is used for planning treatment for ortho and surgical procedures. And also we want to determine the dentofacial growth changes after treatment, whether it's improving or not, because later we want to do follow up of the surgery. First we have to take the cephalometric radiograph. We position CT's head in the cephalometer with head adjusted in natural head position. Sagittal plane of patient's head should be parallel to the film. And next, the lip and teeth should be in the centric occlusion. After we do a cephalometric radiograph, we must do a cephalometric tracing. After that, we must do an interpretation. So that table, the 10 measurement analysis is used because those values must be calculated and be compared to CT's measurements so that we can interpret the results to give a diagnosis of CT's presenting skeletal pattern, and we can know the outcome of the treatment later on. After that, we do a dental mode analysis. We record the arch length measurement, the tooth size analysis, tooth position, arch width analysis, curve of occlusion, cuspid molar relationship, and tooth arch symmetry. So after that, after radiograph has taken, we do a pre-surgical ortho. This phase will take normally 3 to 12 months because we want to move her teeth to a more normal position. So we know that CT has class 2 division 1 incisor relationship with anterior open bite and overjet of 5 millimeter. So the sequence first is the extraction of the upper and lower first premolar. We want to procline the upper incisor and to allow leveling of the arch and to correct the lower anterior proclination. After that, we pasang orthodontic appliances, which are fixed appliances. We put integral hooks with intra-arch elastic attachments between mandibular molars and maxillary anterior. So this elastic will help to produce intrusion of the maxillary anterior or decrease the overjet by retracting the maxillary anterior. And then after ortho has completed, we must take records of the teeth, and we must duplicate the diagnostic model, the cast. So one is kept for record and one is for the surgeon for more surgery. After that, we have to prepare interocclusal wafer splint, the blue one, before stabilizing the arch wire. So the wafer splint must not be more than 2 to 3 millimeter thick. So after we take impression of the wafer splint, we must pasang a stabilizing passive rectangular wire with multiple lugs, the black and white photo, before we pass to the patient to the surgeon to ensure no further teeth movement will occur. So after phase 1, we move to phase 2, which is the surgery part. This will take 2 to 8 weeks. So since CT want to do the orthodontic surgery, we do a bilateral sagittal split osteotomy. So it is just the same as what Afika has mentioned, but instead we pull the jaw backward. Now we want to push the mandible forward. So as usual, the bite block will be inserted I would skip until the step 8 because all the steps above are just the same. So when the procedure is repeated on the opposite side, the medial pterygoid muscle is separated from the inferior border of the distal segment with periosteal elevator, and then bony interferences should be checked, and distal fragment is advanced and locked into desired occlusion. So when it is locked, we lock it with bone plates, leg screws, or intraosseous wiring, and then the surgeon will check if the occlusion is satisfactory. If it is satisfactory, we irrigate the wound with saline and we suture the wound. Next slide. So these are an example of the same clinical case with CT. She has mandibular retrognatism. Picture A is the preoperative one. As you can see, she has the arch wire. And then for picture B, after the surgery has carried out, we can see the fixation has been placed and patient has normal occlusion. And this is 18 months post-surgery. Next slide. So after the surgery, there will a 2 to 8 weeks rest for healing of the osteotomy sites to occur. So after the surgeon has confirmed the satisfactory healing, they will remove the spleen and arch wire and replace by light arch wire, such as in the photo, to allow setting of the occlusion, because normally relapse might occur. That is why we do the follow-up. So the post-surgical ortho will take 3 to 12 months. So immediately after the surgery, we put the arches into desired position to allow settling of the occlusion. And we also use elastics. Next slide. So this is the, okay, sorry, I forgot to mention we have moved to phase 3. So after post-surgical ortho, we do maintenance using retainer. We put Holly retainer at the end of the treatment. And also restorative treatment can be carried out if there is any carious tooth. And we do a follow-up after 1 year to observe improvement of the treatment or if there is any relapse that occur. Because normally at a case journal that I read, there is possible relapse of open bite. So that's all. Thank you.
Okay, she has done this very extensively, Amy. Very well done, though a bit extensive. So all of you, if you want to learn, this whole thing she has answered well, just learn up all whatever she has presented and you have got this part of it covered already. This part of the knowledge covered already, okay? Related to the orthodontic surgery. Anybody got any questions? Amy got anything to say?
No, doctor.
Okay. Siapa pula next? Amnani.
A very good morning to Dr. Santari and all my friends. So today I'm going to present for question 5, which is CT has bilateral impacted lower wisdom teeth that the oral maxillofacial surgeons wants to remove 6 months before the orthodontic surgery. Explain the procedure involved in removing the impacted wisdom teeth and why this needs to be done. So since orthodontic surgery is being suggested for Miss Siti, so prior the orthodontic surgery, most surgeons recommend that third molar need to be extracted because of potential risk of infection and to prevent the interference with the osteotomy sites and to avoid worsen post-operative discomfort, and lastly for the orthodontic indication that being suggested to Miss Siti. And the oral maxillofacial surgeon suggested to do the surgery 6 months before the orthodontic surgery. It is because of the bone need to be healed and remodeling before the orthodontic surgery can be done. And before the surgical procedure, first we need to take the consent form from the patient. Second, we need to take proper clinical and dental history of the patient, and we need to examine extraoral and intraoral examination of CT, and then we need to take radiograph to evaluate of the condition. We can take periapical OPG or CBCT, but the best is OPG to see the surrounding tissue and bone. And then we can classify from the radiograph. We need to classify the impacted tooth to evaluate the difficulty of the surgical procedure based on Winter's classification or Gregory's classification or other classification. And then we need to explain the condition to the patient and the complication that she might get after the surgical. And then we need to select type of anesthesia and prepare for armamentarium for the surgical need to be done. And the surgical procedure for extraction impacted lower third molar. First, we need to reflect adequate flaps for accessibility. The ease of removing an impacted tooth depends on its accessibility. To gain access to the area and to visualize the overlying bone that must be removed, the surgeon must reflect an adequate mucoperiosteal flap. And then the reflection must be of a dimension that adequate to allow the placements of stabilization of retractor and instruments for the removal of bone. And then the preferred incision for removal of impacted third molar is envelope this incision because it's for quicker for the tissue to be healed. And then the incision can be extend from mesial papilla based on the picture. Extends from the mesial papilla of the mandibular first molar around the necks of the teeth to the distal buccal line angle of the second molar, and then to the posterior to and lateral up to the anterior border of mandibular ramus. Next is the flap is reflected laterally to expose the external oblique ridge with periosteal elevator. The retractor is placed on the buccal shaft just lateral to the external oblique ridge, and it is stabilized by applying pressure towards the bone. And this results in a retractor that is stable and does not continually traumatize the soft tissue. And then retractors such as Austin and Minnesota are being used to retract the flap when removing the mandibular third molar. The next step is to remove the overlying bone. Once the soft tissue is elevated and retracted so that the surgical field can be visualized, the surgeon must take a judgment concerning the amount of bone to be removed. So the bone on the occlusal aspect and on the buccal and distal aspect down to the cervical line of the impacted tooth should be removed initially. And then the amount of bone that must be removed varies the depth of the impaction, the morphology of the root and angulation of the root. And then we can use burr such as burr number 8 is for end cutting burr and can be used effectively for drilling with pushing motion. Bone on the occlusal aspect of the tooth is removed first to expose the crown of the tooth. Then the cortical bone on the buccal aspect of the tooth is removed down to the cervical line. Next, the burr can be used to remove bone between the tooth and cortical bone in the cancellous area of the bone. Step number 3 is removal of the impacted tooth. Once the adequate bone has been removed to expose the tooth and the tooth has been extraction, the tooth is delivered from alveolar process with dental elevator. In the mandible, the most frequently used elevator is a straight elevator, cryo elevator, or couplings. Force should be used to luxate